Okay. Excellent. All right. So this week is week 4. We're going to talk about the treatment of attention and developmental disorders. Right. So really, the big topic is going to be ADHD, and we're going to touch a little bit on autism. Not too much, only because there's not many meds that we use for autism, and you're not going to really see too many autistic kids anyway at this point, unless you specialize in it. Once again, Neuron. Okay, I'm going to keep mentioning this again. All the magic happens in the soma. Okay, so remember, action potential has to go down the axon. That would be considered electrical neurotransmission. And then when it gets to the end, it's going to be chemical neurotransmission. And depending on what type of neuron that is, it's going to secrete specific neurotransmitters. All right. Once again, it has to be recycled. There's different ways. Reuptake is a big one, especially now we're going to be talking about ADHD medications. So instead of reuptaking serotonin, what are we going to reuptake? What? Call it out. 2 of them.
Dopamine, norepinephrine.
Very good. Excellent. Right. Okay. Types of neurotransmission. All right. Once again, anterior grade is classical from a presynaptic neuron to postsynaptic. Retrograde, postsynaptic to pre, communicates back. Volume of transmission. We're really going to talk about a lot about that today because we're going to be focusing on tuning the frontal lobe, right? Especially with ADHD. So we're going to be increasing dopamine there. And the reason why it's going to be more effective is we don't have a lot of dopamine transport reuptake pumps, right? So a lot of dopamine is free to kind of travel up, and that's how the medication is going to work. So there's going to be like a dopamine soup that we're going to be creating in a way. Not too much, but just enough to help with focus and attention, all right? Target psychotropic drugs, once again. So the reuptake pumps are going to be 12 transmembrane regional proteins, all right? Upregulation, downregulation, once again. If you block the receptor, the receptors are going to upregulate, right? If you stimulate it too much, you're going to desensitize. And this can happen also with the stimulant medication. Agonist spectrum, all right? Agonist, like the regular neurotransmitter. Partial agonist is a stabilizer. If there's a lot of neurotransmission, it's going to work as a net antagonist. If there's not enough neurotransmission, remember, it's going to work as a net agonist, right? Antagonism, there are some antagonists that we will use, and we'll talk about it later, as non-stimulant medication for ADHD. And we have inverse agonist, obviously, right? Which shuts off the intrinsic activity, and it's going to make that neurotransmitter not work, right? So it's going to shut it off. Or reverse it, either one. Pharmacokinetic versus pharmacodynamics, right? Once again, absorption, distribution, metabolism, excretion. We're going to talk a little bit about pharmacokinetics and how it applies to ADHD medications, specifically amphetamines later on. Again, CYP-drug interactions also. Remember, inhibitors. If someone takes an inhibitor, it's going to increase the dose of any substrates of that medication, right? So if someone's taking a 3A4 inhibitor, like chamomile tea, anything that's 3A4 that they're taking, it could be meds for cholesterol, right? It could be antipsychotic medications. That's going to go up. An inducer, like carbamazepine or phenobarbital, right, is actually going to cause what? Increase the amount of the CYP enzyme, so it's going to break down any other of those meds that use that same substrate, okay? If someone's a rapid metabolizer, that just means genetically they might eat up the medications faster. If someone's a slow metabolizer, sometimes that's even more dangerous. A slow metabolizer usually is more dangerous than a fast metabolizer, except in cancer treatment, right? Because in cancer treatment, sometimes it's the metabolism of the medication that actually makes the cancer medication work. So in that instance, it might be the opposite effect. But normally, slow metabolizer is more dangerous because it can cause side effects even more, right? They're not breaking down the medications as quickly. Pharmacodynamics, once again, what does it do to the brain, right? Everything's working in the CNS, the medications that we're going to be talking about today. So is it a D2 dopamine antagonist? Is it a 5-HT2A antagonist? And those are more of like antipsychotic and mood stabilizer medications. All right. Am I clear? Any questions so far? Nope. Once again, just a good review of the parts of the brain, right? So we're going to talk about ADHD today. So it's going to be dysfunction, most likely in the frontal lobe, right? In the prefrontal cortex, which is broken down a little bit even more. And I'm going to break it down in the next slide when we talk about it. All right. Okay, so this is called the ascending reticular activating system. So I want you guys to look at this. I know there's a lot of like acronyms there, but I'm going to break it down a little bit, the more important ones to know. So LC, what does LC stand for? What is alcine?
Locus coeruleus.
Very good, locus coeruleus, right? So that's the main cell body that creates what? What neurotransmitter?
Norepinephrine.
Norepinephrine, all right? What is Raphe? Raphe nuclei, what does that create? 5-HT, what's 5-HT?
Serotonin.
Very good, serotonin, excellent, all right? So the most important things to really know, and there's a few of them here, but locus coeruleus, definitely know that that's the main part of the brain that's creating norepinephrine, right? Raphe nuclei is one of the brain stems that's in the brain stem that's to create serotonin. TMN, what does that stand for? It's not Teenage Mutant Ninja Turtles. Tuberal mammillary nucleus. Tuberal mammillary nucleus. And that's one of the main parts of our brain that actually creates histamine. Okay. When you give someone a histamine blocker, antihistamine, you're blocking those receptors of the histamine that's being secreted from the TMN, right? Tuberal mammillary nucleus. We have medications that also increase histamine. Do you guys know one? Extra credit. What increases histamine? The medication. Pilots used to take it in World War II to stay awake. Modafinil. Modafinil. So modafinil is a histamine agonist. Some people classify it as a dopamine, increases dopamine also, but the main property of it is actually a histamine agonist, and it does have slight dopamine transport blockade also. It does increase dopamine, but not as much as a stimulant, okay? BF doesn't mean boyfriend, right? It means what? Basal forebrain, okay? So that creates acetylcholine and GABA as well, okay? We talked about PAG last time, periaquidal gray, right? And of course, the thalamus also plays a part in that. So LDT stands for lateral dorsal thalamus, all right? So, but just know the thalamus also creates some neurotransmitters. Know the TMN is for histamine, Raphe is serotonin, locus coeruleus is norepinephrine, all right? The reason why this is important, they're sending reticular activating system. What do you think it does? Look at the arrows. It's innervating your cortex. So at any time, if you block any of those receptors, let's say antihistamine, serotonin blockade, right? Dopamine blockade, what's going to happen? People are going to be sedated. They can't focus. They're going to be off track. So you really want a functioning ascending reticular activating system. This is also very important when it comes to treatment of insomnia. We're not talking about it today, but because let's say, for instance, you know that the ascending reticular activating system is important because it keeps people alert, right? Keeps them awake. And someone's on, I don't know, Benadryl, antihistamine, right? Someone is on Trazodone, 5-HT2A antagonist, and also antihistamine. You're blocking norepinephrine, right? And you're blocking serotonin and histamine. So what's left? Maybe some dopamine blockade, right? So the thing is, you want to understand what receptors are being blocked because you don't want to do a duplicative therapy. You don't want to give 2 antihistamines. You only give 2 serotonin blockers. You don't want to give 2 dopamine blockers, right? So you don't want to repeat treatment. It's a waste of time. Obviously, if one's not working, why repeat it again? So sometimes you might have to block all of those receptors to get someone to sleep, right? Or you might just increase GABA. GABA is universal. It'll die down. It'll tie down all of that. But why use GABA right away if you can use a smaller weapon, right? Maybe just blocking histamine by itself will put someone to sleep. You don't always have to use the big guns. Like you don't have to go to Zolpidem or Lunesta right away, right? Maybe try antihistamine first. That doesn't work. Maybe try melatonin. That if they have a depression, maybe use Trazodone because it's a 5-HT2A antagonist, and it also has serotonin reuptake inhibition also a little bit, right? Buy one, get one free. It's a twofer. Any questions with that? This is a very important concept to understand, is that in psychopharmacology, you don't want to repeat the same treatments, all right? You want to make sure that you do it systematically. Okay, I'm blocking this person's histamine, they're still not sleeping. I'm blocking this person's dopamine, and now they're not tired, and then they can't even focus, and they have no energy, right? So if you're giving someone a dopamine blocker, and they say, you know, now all of a sudden they have anhedonia, in your mind, you say, okay, maybe I'm blocking too much dopamine, all right? That's why it's good to understand these concepts of what each neurotransmitter and what each, pathway does through a person, okay? Any questions? Clear?
Can you repeat the neurotransmitters that affect Trazodone?
For Trazodone?
Mm-hmm.
Yes. So Trazodone at low doses at 50 milligram is a very potent antihistamine. So it blocks histamine receptors, antihistamine, right? It's also a 5-HT2A, serotonin 2A antagonist, right? Which is why sometimes we use it for sexual dysfunction. Because like, remember, I told you guys, 5-HT2A is a dopamine brake, right? So when you cut the brakes, you increase dopamine. So that sometimes that can work with sexual dysfunction, all right? It's also an alpha blocker, alpha-1 blockade. Why would you want to block alpha-1 receptors? What is hyperactivity of alpha-1 receptors in the brain do? It triggers what? Fight or flight, right? People in a very sympathetic state, that means their locus coeruleus is secreting a lot of norepinephrine, and all that excess norepinephrine is binding to different parts of your brain, right? Limbic system, the amygdala, hippocampus, anterior cingulate cortex, all these parts of the brain that are causing different things. Fight or flight response. Remember, we talked about para-acridal gray last time. That's going to increase your respiration rate. People are going to start panicking. So by blocking the alpha receptors, you're cutting down the fight or flight response, and helps people kind of relax. That's why we give them what? Prazosin for what? Nightmares and hyperarousal. Does that make sense? All right, so these are the malfunctioning parts of the brain in ADHD. So DLPFC stands for.
I have a question.
Yes.
Does the alpha receptors, do they also block norepinephrine?
Presynaptically. We're going to talk about
not
that
block,
also.
I'm sorry. Oh, okay, all right.
Presynaptically, yeah.
Presynaptically, okay.
Postsynaptically, right now, innervation of the postsynaptic alpha receptor is going to cause a fight or flight response, and it also will start the cascade of your we talked about it last time, the HPA, right? Hypothalamic pituitary adrenal axis. So it's going to increase cortisol, and that same feedback loop is going to cause someone eventually to cause, that's why sometimes anxiety, especially in children, they say anxiety precludes depression. So a lot of times kids will have an anxiety disorder first, and that's going to cause hyperactivity of the hypothalamic pituitary axis. Over time, that's going to cause shrinkage of the hippocampus, shrinkage of the connection of the frontal lobe to the amygdala, right? And then the amygdala is going to start hyperfiring, and that's going to cause depression eventually too. And and it's interesting because you see anxiety with depression a lot because the pathways are kind of intertwined, right? They're not working in individually, they're working all together in the brain, right? Questions with that? I know this isn't a child psychiatry course, but we are going to do a lot of child psychiatry today because obviously predominantly are going to be kids for ADHD. I do treat some adults for ADHD also, and we'll talk specifically about that as well. All right.
Professor, we're going to get this PowerPoint after, right?
Yeah, of course. Yeah.
All right, cool. Thanks.
Yeah. It's $50. You're going to have to send it to me on my Venmo, and I'll send it to you.
That's fair enough.
So DLPFC stands for dorsal lateral prefrontal cortex. All right. DLPFC, that's cognition. And to be more specific, that part of the brain is more involved in sustained attention. All right. So if someone has issues in their dorsal lateral prefrontal cortex, they might be the kid that can't actually stay. Like if you're telling them a story, after about 10 seconds, they're going to start looking out the window. They're not going to be able to focus. All right. That's sustained attention. Ventral medial prefrontal cortex has to do with affect. And even though it's not in the DSM, but it's pretty well known that ADHD also has an emotional component to it, right? They also have emotional lability. The reason why they didn't put it in there, and this is just speculation, is because if you put the emotional component in ADHD, it will be very hard to distinguish it from a mood disorder, right? Like hypomania, for instance, because they also have issues with attention, and they have, movement. They're moving fast when they're manic, very energetic. They also can, it looks almost the same, and they're comorbid also, right? Orbital frontal prefrontal cortex is OFPFC. Orbital, your eye, frontal in the front, so it's actually right above your eyeball, prefrontal cortex. And that's implicated in a lot of our illnesses, but in ADHD, it has to do with aggression and impulsivity. All right, so there's an issue in that brain circuit. Once again, DLPFC is cognition, more specifically, sustained attention. Ventromedial prefrontal cortex is affect, all right, which is the mood lability that we sometimes see in ADHD kids, right? Which sometimes gets confused for bipolar 2 sometimes, right? Prefrontal motor cortex, we all know what that is, obviously, your motor cortex, hyperactivity, okay? Anterior cingulate cortex stands for motor symptoms and selective attention. So the anterior cingulate cortex is implicated in a lot of disorders, but ADHD, it has to do with motor symptoms and selective attention. Has anyone ever heard of a Stroop test before? A Stroop test?
Only in a textbook.
What is it? What is a Stroop test? Okay, Stroop test means that you have someone do a test, and what they'll do is they'll give you it's going to say a word, right? It's going to say blue on it, but it's actually going to be in the color orange. And you're going to tell the patient, okay, I'm going to give you some, words, that are not going to be the same color as those words. So you might say blue, but it's actually yellow, or you might say red, but it's actually blue. But you're going to tell them, look, I don't want you to read the word. I want you to tell me the color that you see. So it's working on selective attention. You have to zone out your natural reflex to blur out the words and actually look at the color. So if you see a word that says red, but the color is blue, what are you going to say? Blue. All right. And you have to really focus and try to block out the extra stimuli. And that's called the Stroop test. And that's a test for selective attention. We also do a test for sustained attention, which is called the NBAC test. NBAC is when you subtract a certain amount from a number, and that number count keeps going up. All right. And we'll see how much more you can do. So it might be NBAC test by 7. And it's going to be like 7 numbers they have to subtract 2. And it keeps going until you can't do it anymore. All right. So just know Stroop test is a test for selective attention. NBAC test, which is usually N, it looks like a minus sign, dash. Back test is how we assess for sustained attention. They usually do that in like ADHD clinics. We don't really do that in outpatient. It takes too much time. All right. Important concept to understand is that ADHD is not just like not enough neurotransmitters, right? Sometimes people classify, well, you don't have enough dopamine, norepinephrine. It's really not too much or too little. It's more of like keeping it tuned. So sometimes we have something called the bell curve, right? You guys know what a bell curve is. And the most effective attention and focus is actually not to the right or to the left. It's actually in the middle of the curve. All right. So if you have not enough dopamine or epinephrine, you'll be on the left of the curve, and it's still not going to be efficient, right? Or if you have too much on the right, it's still not going to be efficient. There has to be something in the middle. So sometimes having not enough dopamine will cause increased noise, because dopamine actually decreases the noise. All right. Noise means that like you get distracted. So you might be in school and you're listening to the teacher and you hear someone mowing the lawn and you have to stare out the window, right? You don't have good selective attention, so you get distracted right away because you get distracted by that noise. Or the signal might not be strong enough, right? So there's not enough norepinephrine to keep that focus on, all right? So not enough norepinephrine, the signal is not strong enough to make it to that postsynaptic receptor, right? Not enough dopamine, there's too much noise. So if you look at the style book, it kind of illustrates it as there's like electricity leaving and not being insulated, right? There's not enough dopamine there. So the noise is like leaking out, right? And norepinephrine, obviously, like I said, increases the signal. Any questions?
Yes. So Saul was going over in his video, basically, he was explaining that it could, like you're saying, it's it's a tuning, you got to tune it and bring it back to the middle. But I don't understand how giving a stimulant when you have dopamine is elevated and so is norepinephrine, how that's going to bring it back to the middle. Wouldn't it make it worse?
It could. The challenging part is that, our meds are very broad strokes, and we want to make sure, and sometimes we want to adjust one part of the brain, but it affects, remember, like an antipsychotics, it affects the whole brain. So maybe you might just want to increase dopamine, for instance, in the frontal lobe, right? But obviously, when you take a stimulant, it also can innervate dopamine receptors in the striatum, which is where you don't want it to innervate, because that's the mesolimbic area. So it can cause psychosis. So it's a little bit of like adjusting it in a way and finding a middle ground. Unfortunately, we don't have we don't have any like tests to kind of see if someone has a dopamine deficiency or norepinephrine too high, and we kind of have to play around a little bit with the medications. So which is why we use a lot of polypharmacy sometimes. You might give someone an alpha-2 agonist, right, which increases norepinephrine at the presynaptic receptor, and you might give them, I don't know, Adderall, which increases dopamine and norepinephrine, right? You're kind of balancing it out a little bit. Okay, we're going to talk a little bit more about that in when we get to the treatments. But just have a general understanding of the circuits, right? It's not just the frontal lobe, specific parts of the frontal lobe, right? The dorsolateral prefrontal cortex of the frontal lobe, cognition, sustained attention, ventromedial prefrontal cortex of the frontal lobe has to do with affect, orbital frontal prefrontal cortex by your eye has to do with aggression and impulsivity, prefrontal motor cortex, obviously listen to motor, hyperactivity, all right? And anterior cingulate cortex has to do with selective attention, all right? Know that if you don't have enough dopamine or there's a deficiency in dopamine, there might be too much noise, right? You're getting distracted all different parts. If there's not enough norepinephrine, the signal's not strong enough, and they can't focus either. Okay. This is important. What is this? Guess what medication this is? What does that look like? That's called no, that's called Concerta. This is called Concerta. This is methylphenidate, right? The reason why this is important is because you kind of want to have an understanding of how the medications work. Because if they don't work on a patient, you can kind of figure out what kind of deliveries. So we only really have two types of stimulant medication, right? There's two large classes. Anyone want to list it to me? You have the what class and the other class, not non-stimulants or stimulants. I'm talking about stimulants right now. What are the two types of stimulant medications that we have?
Amphetamines and
Very good.
methylphenidate.
Very good. Would you like to explain to me what the difference is?
Sure. I think it's based off the mechanism of action, right? Isn't amphetamines have like a couple ways that they work on ADHD, and methylphenidate blocks NET and DAT.
Yes. Yes. So they both work on NET and DAT, but amphetamines, there's a slide on that later, which we'll talk a little bit more in detail, also is a irreversible substrate for the VMAT. So it blocks the VMAT, and so dopamine can't go inside the vesicular transmitter, and it actually reverses it. So it'll spit back dopamine also, and at the same time that it's blocking inhibition. All right. So it's actually quote unquote more potent than a methylphenidate, which is why sometimes we see amphetamines triggering psychosis or mania a lot more than methylphenidates, right? It's pretty well understood that methylphenidates tend to be a little bit safer than amphetamines when it comes to treating ADHD and not triggering. They both can in theory, but you see it a little bit less. It's ironic that, you know, primary care physicians and regular primary care NPs prescribe amphetamines more, and specialists like psychiatrists or child psychiatrists actually prescribe methylphenidates more. I don't know why that is, but that could be a reason why. We're more cautious in triggering a mania or a manic episode. Okay, so look at this picture, and the way it works is it's called OROS, OROS, which stands for osmotic releasing oral solution. All right. The reason why that's important is because Concerta, which is the brand name, first came out, and it had this technology. And when eventually once it lost its patent, they started making generic versions, but this technology was patented, so they couldn't make it. So what was happening is that kids were stable on Concerta, but then when they went to generic methylphenidate, it just stopped working. And the reason why is because it's this technology. So if you look at drug layer 1, that layer actually has immediate release methylphenidate in there. All right, and layer 2 has extended release methylphenidate, and then the push layer is actually water. So what happens is the water using osmosis is going to push out drug layer 1 first, which is what you want, right? You want drug layer 1 to push out first, which is immediate release, which is going to work fast. While immediate release is working, layer 2 is going to come out, and that's extended release. So, that's how you get the extended release formulation, which lasts, I think, between 8 to 12 hours, all right, of methylphenidates. Any questions with that? So the reason why that's important too is because sometimes people's insurance are not going to pay for the brand name, right? You write a script for Concerta, and they're going to say, no, we only cover, generic, which is called methylphenidate ER. You have to write on the script for the pharmacies to know, please use generic solutions that use OROS technology. Because what happens is if they want to cheap out and they buy something that's like not OROS, it might just be put in a wax film. And the wax obviously is inferior technology because it gets dissolved by your stomach. The kids, either the meds are not going to work long enough or it's not going to work at all, right? Does that make sense? So make sure you write specifically OROS technology if you are going to prescribe methylphenidate. That's happened to me in clinical practice. So what I did was, the kid, all of a sudden, the mom was like, well, the meds aren't working anymore. Can you increase it? So before I increased the medication, I called the pharmacy and I said, hey, did you switch generic companies? They said, yes. Okay. Can you please get another company, even if it's a little bit more money, because they need something that has OROS because they don't respond to anything else. Does that make sense? Any questions? No. Okay. All right. What you see is what you get, okay? I don't have to read this to you. This is just a DSM criteria for ADHD. All right, know it. You might ask you a few questions on the final about it. Remember, symptoms have to be before age 12. Prior to DSM-5, it had to have been diagnosed before age what? Do you guys remember? What was DSM-4? Age 7. So before DSM-5, someone had to get these symptoms and diagnosed before age 7. But what they realized was there was a lot of people that were still having symptoms after that. So in order to capture more patients, right, and provide care for people who needed it, they expanded that age to age 12, okay? So they had to have at least 6 of 9 symptoms of inattention or 6 of 9 symptoms of hyperactivity, all right? There's 3 subtypes. There's ADHD subtype more inattentive, there's ADHD subtype that's more hyperactive, and there's mixed, okay? Any questions with this? Pretty self-explanatory. For adults, you only need 5 out of 9 symptoms, okay? Keyword is that it has to occur in at least 2 places. So whenever you have a kid, you want to diagnose them ADHD, we usually give them scales. I use the Vanderbilt, okay? So I give a scale to the mom, she does it for home, and then I give a copy to the teacher, or I give it to the mom to give to the teacher, and the teachers have to score it also. And they have to at least meet the threshold in both places. If it's only happening in school, or only happening at home, we don't diagnose as ADHD, right? We try to figure out what's happening environmentally in the home, or what's happening environmentally in the school that's causing this kid to act out, right? Or not be able to focus. Does that make sense? So it has to occur at least 6 months, okay? So how I remembered was 6 of 9, 6, 9, 6. So 6 symptoms of 9 in 6 months, right? By 12. 6, 9, 6, 12. 6, 9, 6, 12. 6 symptoms of 9 for at least 6 months before age of 12. That's how I remembered it, but that's for kids. For adults, it's 5 symptoms of 9, right? And sometimes, what do you do if an adult comes to you and says, I have ADHD? What do you do? I'm just curious. It's a very controversial topic, but how would you screen them if you didn't know them at age 12, and now they're like 35 years old and they're saying you have ADHD? What do you do? Someone chime in. Tell me what you would do. Would you prescribe them a stimulant?
No, maybe like a non-stimulant first, or like a long-acting.
Why is that? Why would you do? Why a non-stimulant? Or just curious.
Well, just because they might have history of substance abuse that you don't know of.
Excellent. So just that you guys know, you don't diagnose ADHD by giving someone a stimulant and they say they feel better and now they actually focus, right? Because everyone you give a stimulant to is going to perform better in school or be able to focus, except if they have obviously an underlying mood disorder or underlying psychotic disorder, and then you trigger a psychosis with them, right? But most people, if you take an Adderall, you'll be able to focus, right? It might increase your anxiety a little bit, but you'll be able to focus. So just because the patient says now I'm doing better doesn't necessarily mean that they had ADHD. All right. You want to do a thorough history. So number one, you want to make sure that if you can get a family member to collaborate it and say, hey, when they were a kid, yes, they were having issues with school. Sometimes you can ask if you want to be very thorough, you can ask, can I see your report card? All right. If they have it, they'll probably laugh at you, but if you have anything, is there a family history? Right? Is there anyone else in your family? Because there might be genetic loading. ADHD is highly genetically loaded. So if there's a family history of ADHD, there's a high likelihood someone else will have it as well. Okay. Any questions? This is pretty self-explanatory. Okay. Don't worry about hyperkinetic disorder. Focus more on ADHD for now. That was just in the slide. So this, this is just a picture to show the differences between amphetamines and methylphenidates, right? As Brian explained pretty clearly, amphetamines have a double mechanism. Not only do they block the reuptake, they also go on the VMAT and they increase the release of dopamine. That's why the abuse potential is much higher in amphetamine, right? You're probably safer using a methylphenidate, and even safer is using an extended release formulation, all right? Why is it more dangerous to use an IR as opposed to an ER? What does an IR do that an ER might not do?
It hits the receptors harder, so it causes more like a phasic firing.
Yes, yeah. So it's a much stronger punch, for instance, and it can reinforce the nucleus accumbens and make it, if you have the genetic loading for someone who has an addictive personality disorder or a family history of substance abuse, you give someone an IR stimulation, they feel good. Now now it's hard for them to get off it because they want to reinforce that, right? If you give them an ER, it's going to hit the receptor not as hard, enough for them to focus, but not hard enough to cause euphoria. All right. So methylphenidate works on dopamine reuptake and norepinephrine reuptake. Amphetamine does the same thing, but it also works on VMAT, and it reverses it. All right. If you look at this picture, that's pretty much what it shows. So if you look at A over here, right, it's not working on VMAT because look, they're actually going inside the vesicle, right? If you look at number B, it shows it coming out, right? You actually see it releasing those neurotransmitters out of the vesicle and it's coming out because it's reinforcing it. Is that clear? Any questions? This is just a list of some short acting. Last I checked, I think there's like 26 or 27 stimulant medications for ADHD, right? That's a lot, and they're adding a lot more, but it's still the same formula. It's still the same mechanism in a way. You're either, you know, blocking the VMAT or blocking reuptake pumps, and either you're using methylphenidate or you're using amphetamines. But, you know, obviously there's different formulations. There's extended release formulations. There's intermediate release. You have short acting release. You have very, very long ones too. There's something called Jornay, which it's not here anymore, but it works very long. You actually take it. It works so long. You take it the night before. You go to sleep, and then it kicks in when you wake up. So this is actually, I've never prescribed it before, but the rationale for this is, how do you get a kid who's grumpy in the morning to wake up and take their medications, right? You give it to them when they go to sleep. They wake up, it kicks in, they're able to get out, go to their school bus, and go to school without any issues. All right. So it's like it's a delayed onset medication, but it's extended release, very long. Okay. My recommendation is, obviously, I don't expect you guys to memorize all of these medications, but just know if something has ER or XR at the end of it, it's an extended release, right? If it doesn't have ER or XR, most likely it's immediate release. All right. In your practice, you know, what I did in the beginning was, you know, I got comfortable with one amphetamine immediate release medication. I got comfortable with one, you know, methylphenidate immediate release, comfortable with one extended release amphetamine, and comfortable with one extended release methylphenidate. All right. Because there's so many of them. I'm not even talking about isomers right now. We still have isomers, which is a little bit more advanced, but I'll talk about the isomers when you guys are in clinical practice of how you would use one over the other. But in a general sense, just know that in the beginning, you know, you might use an immediate release first, but then bridge them to an extended release. Okay. I'm talking about kids, not adults. With adults, I will go directly to extended release first. If I'm doing it with kids, why would I start with immediate release first and then go to extended release? Anyone want to chime in? Why? For children. Why do IR first before going ER?
I guess you want to see if there's an improvement in symptoms right away, and also there's also a component of hyperactivity and impulsivity that's not really seen in adults.
Okay. Yeah, you answered part of it actually. Yeah. So the reason why I use IR, because it's a tolerability issue, right? Not really an effectiveness issue. Sometimes kids get something called a paradoxical reaction, right? It happens a lot with young kids if you give them a stimulant. So the thing is, if you give them an extended release right away and the kid gets a paradoxical reaction, they end up being more hyperactive, or they have they get hyper focused, and the mom is like, oh my God, I'm scared. They're like a zombie and it's not working. At least you can tell them, look, it's only going to last for a couple of hours. It's going to wash out, and you can reassure them that they'll be fine, right? But imagine you give someone an Adderall ER or extended release version, and now they have that side effect. The mom's going to be freaking out, right? Or the dad's going to be freaking out. And they're going to say, oh my God, my kid's been like this for 6 hours, 7 hours. What do I do? So what I usually do is I'll prescribe an IR first, and I'll tell the mom, look, start the medication not on the school day. Start it on the weekend. Start it on Saturday when you and your husband are home, and you guys can monitor when the medication kicks in. I expect it to kick in within a half hour to an hour, right? You should see your kid calmer, more focused. And then within 3 or 4 hours or 2 or 3 hours, you start noticing, it wearing off. And I want you to tell me at what time that medication starts wearing off, okay? Then the second week, I'll come back and I'll give them 2 doses, all right? Maybe Adderall 5 milligrams. 5 milligrams after breakfast, 5 milligrams after lunch, right? Then you let me know when it wears off. So once we find the dose, it might go 5-5 and then 10-10. I'll convert that to extended release, right? Because extended release really is similar to having 2 dosages of the Adderall. So Adderall ER 10 milligrams is equivalent to getting Adderall 5 milligrams after breakfast and Adderall 5 milligrams after school or after lunch. Does that make sense?
Yeah, I was going to say, is that really the practice now? You just kind of, after a while, you just prescribe the extended release because it's easier.
You really want to give people extended release because it's better, because you avoid rebound, which can happen with immediate release a lot. So rebound could be irritability, right? It could be low moods also, or fatigue. So you want to give them just enough coverage so that they can get through the whole day, and then they can rest peacefully. All right. That's the way I do it. All right. It takes some homework, and it might take you like a month or 2 to 3 weeks. But I see patients every week, and I tell the mom, look, the good news is once you get them on the right dose, depending on how young they are. So if you give, I don't know, the youngest I've diagnosed with ADHD is like 6, 7, around there. Once they hit puberty, you might have to adjust a little bit more. But once they're like 17, 18, and they're about to go to college, that dose stays until they're an adult. It's the same dosage. So, just getting them on the right dose and tweaking it a little bit when they're an adult, that's going to be the dose. If they want to stay on it chronically, lifelong, that's it. It's just in the very beginning, you want to make sure that you're precise in dosing it. Any questions? Okay. Long-acting non-stimulants. When would I use a non-stimulant as opposed to a stimulant?
If they have history of abuse.
Substance abuse, right?
Yeah.
Good. Okay. What else? Any other reasons?
Maybe if they have like cardiac issues.
Yeah, you could. Yeah. That's another one. Give me one more.
If they didn't respond to the stimulant?
Very good. Yeah. Okay. Yeah. Excellent. I was waiting for that one to be the first answer. Yes. About 30% of patients actually don't respond to stimulant medication, right? So you have a 70% response rate with any Concerta or methylphenidate or amphetamine, but there's going to be 30% that don't. So, you might have to put them on a non-stimulant, or even better, which I like to use sometimes, is I combine them. So I use a stimulant and a non-stimulant. Why is that? Why is that better than just using one? I know we try to avoid polypharmacy, but this is one of the instances I'm actually using both meds might be beneficial for the patient.
It covers like all areas, I guess, because if one might not be working, he just needs a little additional.
That too, yeah. And give me another one. There's something else. You have to think a little bit more though. What is it?
Does
What's the
it,
side effect of stimulants?
Hypertension,
Good.
tachycardia,
That's okay. What else?
insomnia.
Yes, but insomnia, very good. One, insomnia is one, right? Or anxiety. So what is the side effects of non-stimulants? It's like peanut butter and jelly, right? They complement each other. Each one, that's why I tell parents, they usually laugh. Peanut butter and jelly, they're great by themselves. When you put them together, it's even better, right? It's like magic. So what'll happen sometimes is the mother will say, oh my God, they're great, but now for whatever reason, they can't sleep at night or they get anxiety at night. So I say, okay, great. I'm sorry that it happened, but maybe we can add Clonidine, because Clonidine will also allow me to reduce the stimulant sometimes once it kicks in. And then you'll have, a medium dose of a stimulant instead of a high dose, and a medium dose of Clonidine when you have both at the same time. So the Clonidine will kind of take the edge off at night and help them sleep. And at the same time, it's affecting norepinephrine, and it kind of gives you a little bit more norepinephrine activity that maybe the stimulant's not giving you. All right. So I combine them both. Obviously, you're not going to do it right away. You want to try to maximize one first and see, and then you can add the Clonidine. Usually I'll add the stimulant first, and then we'll see if they're having issues with insomnia or anxiety, and I'll add the alpha-2 agonist. Okay. Sometimes it's not that people can't tolerate the stimulant, but actually it's true. They can't tolerate it because now they're saying they're losing weight, right? The mom is saying, well, my kids hasn't been eating, the pediatrician's annoyed that you have them on stimulants because they're below the growth curve, right? So you say, okay, we can either go down on the stimulant and add Clonidine, or we can get them off the stimulant and just do an alpha-2 agonist. But just be aware, it has to be taken every day, and it doesn't work right away. It takes about 2 to 4 weeks to kick in. So there's a delayed reaction to it. Sometimes what you can do is you can add a stimulant first and see if it works. But if they can't tolerate it, tell them stay on the stimulant for a couple of weeks until the Clonidine kicks in, then you can get off the stimulant. Because then that'll, similar to like how you bridge SSRIs with benzos. The benzos there in the beginning, right? Because they work right away for anxiety. Then you get them off once the actual real treatment kicks in. Does that make sense? When would I use? Yes.
I have a question.
Sure.
What about for, I know like in clinical practice, I've seen kids who, are that have ADHD, but their side effect is like appetite suppression, especially for like younger kids who like you were saying, maybe don't meet some sort of developmental growth patterns. How do you combat that?
Good. That's a great question. There's a lot of nitty-gritty stuff in treating ADHD. That's why it's a specialty, but we'll all touch a lot of these specific techniques too. That's a great question, Phil. So with that patient, you would actually use IR, because what happens is once the medication is going down, that's their time. That's when their appetite comes back. They can eat, right? So I'll stay. Question, anyone? Okay. So you give them an IR in the morning, right?
Yeah.
It starts to wear out. Then they have a decent lunch. Then they take the medication again. The downside to that, obviously, is they're prone to rebound. The rebound's going to kick in. But if they want to have an appetite and eat, that's the technique you can use. Use an IR, eat a good meal, take the next dose again. Once it wears off, you eat again. If you need a third dose, you can take it again.
I see. Okay. And you wouldn't be worried about a middle day dose for a kid affecting sleep at night, or would you just?
Well, that's
Coming
again,
in.
that's it's funny. I can stay on ADHD all day. It's like a specialty.
Yeah.
Yeah. The good thing is you can do, let's say what I'll do sometimes is I'll do, let's say 10 milligrams in the morning of Adderall IR, right? 10 milligrams at lunch, and then we'll do 5 after school. So it's not a 10, and you kind of have to like tweak it that way.
Okay.
So instead of like equal doses, it'll be 10, 10, 5.
And then, okay, got it.
Yeah, cool.
Thanks.
And that's why like the parents have to play a role in it also, because obviously an outpatient, you're not observing the patient. So I tell the parent, look, you need to have some homework because I want to be as precise as possible. I don't want to over medicate your kid, and I want
Right.
to know how they're metabolizing the medication. So they should keep a book, and they can write down when it starts working and when it wears off. And when you look at that book together during your session, and you can kind of figure out, okay, it looks like it's wearing off too fast in the evening time. So let's raise the dose a little bit in the evening time.
Got it.
All right.
Cool. Thanks.
Remember also amphetamines are what? They're weak bases. Anyone here remember chemistry? What happens if something is a weak base? And it goes in the stomach. If it's a weak base, it gets excreted faster, okay? It's a weak base, so when it goes into your stomach, and if your stomach is more acidic, and how do you make your stomach more acidic? You take what? A lot of things can make your stomach, but in clinical practice, it would be like someone, COVID, right? 2 years ago, when COVID was really at its peak, every parent was giving their kids emergency. Remember emergency? You would put it in water, it would dissolve, and you would drink it because apparently they thought that by drinking a lot of vitamin C, you would have less likelihood of catching COVID. These same kids, their ADHD meds stopped working. Parents were like, I don't know what's going on. Now it's not working. And I said, well, have you been changing any diet? Are they eating citrusy stuff? Are they? And then when they said, well, we're giving them this so that they don't catch COVID. Like, okay, there you go. What's another name for vitamin C? Come on.
Ascorbic acid.
Very good. Ascorbic acid is an acid. All right. So if you take a lot of vitamin C and you make your stomach very acidic, that's going to cause your body to excrete that extra amphetamines and stop working. So what do you do then? What do you do if they're like, you know what? I don't care. I want to take vitamin C. I don't want to get sick. What do you do?
I guess you switch them to a non-stimulant or methylphenidate.
Very good. Excellent. Methylphenidate. Methylphenidate is not affected by the pH of your stomach. Okay. You can just say, well, except if they tried methylphenidate, it didn't work. Then you have to compromise with them. Look, I know you want to take the vitamin C, but it's going to cause your medications to not work anymore. You tell me what's more important, your vitamin C levels or your ADHD, right? You can try a non-stimulant also, but the effect size is not that strong. The effect size of a non-stimulant is like 0.5. The effect size of a stimulant is like 1. It has the largest effect size of any medication in psychiatry. Very strong effect size. Someone takes it, they feel it right away. All right. Non-stimulants, it's not as strong as a punch. It might work a little bit, but it's not going to be as strong of a punch. And you have to tell patients that. All right. Strattera. Strattera is works a little bit different. What does Strattera do? It's a what? It's a non-stimulant, but how does it work? It blocks what? What pump?
Does it only block norepinephrine? I'm sorry.
No, yeah, I was gonna say the same thing. It blocks the.
Very good. Yeah, only norepinephrine. Okay, but by blocking norepinephrine only in the frontal lobe, it's actually working on both norepinephrine and dopamine. Okay. The good thing about that is that if it blocks norepinephrine, it's not going to increase dopamine in the striatum. It doesn't cause psychosis. Why? Because if you give someone a stimulant, it's going to block the dopamine reuptake pump in the mesolimbic area also at high enough doses. All right, so that can cause psychosis. But if you give someone a norepinephrine reuptake inhibitor like atomoxetine or Quellbree, which is called viloxazine, which is a neuromedication, it's only going to block the the norepinephrine reuptake pump in the frontal lobe, and it's not going to block dopamine transport pump, so it's not going to affect the striatum. It's not going to increase dopamine in the mesolimbic area, causing psychosis. It's only increased dopamine in the frontal lobe, which you want to, right? Because it's blocking the norepinephrine transport pump, which is involved in reuptaking dopamine also. So you're keeping increased dopamine there using volume neurotransmission. Does that make sense?
So the amphetamines and methylphenidate kind of, I know they have like different mechanism of actions, but they kind of work the same, that they could both increase the dopamine in the frontal cortex and elsewhere, right?
It can, yeah. But methylphenidate is safer because it doesn't increase the release of it. Only increases what's already there by blocking the pumps. It doesn't reverse VMAT and cause more to go in.
Oh, yeah,
Actually less,
okay.
yeah, less addictive. But methylphenidates can still be addictive, all right? All right, this is a little bit of a longer list, but you guys will have this slide with you, but just remember, it gives you how long it lasts, that's the duration, and it also tells you what else does it tell you in here? The starting doses. All right. Any questions with this? So notice Wellbutrin is also used off-label for ADHD. Okay. So I use Wellbutrin if someone has an underlying mood disorder, let's say depression, and they say I have issues with cognition. All right. I don't diagnose them with ADHD. I'll say, well, let's treat your mood symptoms first, and then let's see if the attention is still there. So you shouldn't diagnose someone with ADHD unless they're treated for the other symptoms. All right. So there's something called diagnostic hierarchy. Philip, you should know diagnostic hierarchy. I've talked this to you guys a long time ago, but what is it? What is a diagnostic hierarchy?
Figuring out like which symptom is most clinically impacting the patient or clinically significant.
Okay, that's one of them. What else? What is that? It tells you what to treat first. Okay. So you treat the bigger disorder first before you treat the smaller disorders. Okay. I'll give you an example. Someone comes in and they have a history of mood disorders and they're saying they have ADHD. Okay. And they also have a history of trauma and they also have a comorbid, I don't know, marijuana use disorder, right? Many different, which is common. You see a lot of patients come in and they have different issues happening, right? What do you treat first? Obviously, number one, ideally, you want to get them to sober up, all right? Get them to a rehab or get them to stay, stay away from any substances because they could be substance induced. Once they're sober for a couple of months and the symptoms are still there, what do? Then you treat the underlying mood disorder, right? Whether it's bipolar or MDD, right? Once they're euthymic, then you see, okay, I still have anxiety. Okay, then you treat the anxiety. You treat the anxiety, they still have inattention. Then you can accurately diagnose ADHD if it's still there, okay? But you don't do ADHD right away because what happens if you give someone a stimulant? You're going to worsen their anxiety. You're going to worsen their mood disorder. You might even cause them to be manic. You might worsen their anxiety, okay? If they have comorbid substance use, you're going to spiral them back to using even more substances, right? Any questions? Do you agree with that? No? Okay.
Yes.
So,
Yes.
so what happens if you have somebody who has like an anxiety disorder and ADHD? You would first treat anxiety?
That's a tough question. When I was in school, that was what I was trained to do, and that's what I learned. But in clinical practice, the answer actually is no. Because there have been like a bunch of patients that I had that when I treated their ADHD, their anxiety actually went down because their anxiety was secondary to the ADHD. And it's hard for you to tease that out. So sometimes you might have to just like do a good thorough interview and try to figure out, was your anxiety, triggered by you not performing well at work or not performing well in school? If that's the case, and we're positive about that, then we'll treat that first and see if your anxiety goes down with the ADHD. If it's not clear, then I'd probably treat the anxiety first because I don't want to worsen your anxiety by giving you an ADHD medication first. Obviously, that's shared decision-making and you have to talk to the patient about it and give them the pros and cons of going one way over the other. All right.
Thank you.
No problem. So if you look at this here, there's a lot of like off-label stuff here too. So look, Wellbutrin off-label for ADHD. Okay. There have been some positive studies only in children though for Wellbutrin to help with. They did studies in which kids had underlying mood disorder and ADHD, and Wellbutrin was able to work with both, not in adults. Okay. Provigil almost got FDA approved actually for ADHD in kids. But what happened? They pulled it off the market because apparently 4 or 5 kids in that study developed Stevens-Johnson syndrome. So they stopped it. They didn't get the indication for that. Okay. Intuitive and Tenex are the brand names of Guanfacine and Clonidine. Okay. Capve, I'm sorry, is actually Clonidine. Intuitive is Guanfacine. So just know if you're prescribing alpha-2 agonists, IR for ADHD, which I do sometimes too, it's going to be off-label. It's not going to be FDA approved, right? In order for it to be FDA approved treatment for ADHD, alpha-2 agonist, it has to be the extended release versions, okay? Sometimes I'll try the IR first and it still works because I don't feel like doing a pre-authorization. And to me, they're just as effective. But if you want to actually go by FDA indications, it's actually going to be, the long-acting ER versions of both, okay? And they have the Cipramine. What class of drug is the Cipramine here, off-label? It's what? Tricyclic. All right. The reason why I'm using a tricyclic is it's actually a stronger norepinephrine reuptake inhibitor. So why use the Cipramine if you can just use atomoxetine, right? Without causing the other anticholinergic side effects of disipramine, tetracycline. Any questions? Side effects of treatment, once again, stimulants, obviously, it suppresses your appetite because it's a stimulant medication. So anorexia could be a side effect of it, right? Insomnia, obviously, because it's stimulating. Stunted growth, it actually suppresses growth hormone. So kids will actually, they might be a little bit shorter. There's some studies that say it just delays it, but again, it's mixed. There's some studies that will tell you that they eventually will get that inch back or 2 inches a little bit later on in other kids, but there have been other studies that show that it doesn't. So I present I present both information to the parents and to the kids, and they decide what they want to do, if they're comfortable going on stimulants. All right. Obviously, it's a psychomimetic, so it can cause psychosis and cause mania, and it also increases anxiety. Okay. Side effects of non-stimulants usually just GI side effects, headache, and fatigue. Those are the most common side effects, which happens a lot with atomoxetine, which is why usually I'll dose it, twice a day, slowly, and then we'll adjust it very slowly from there. All right. All right. We're going a little bit into detail because, I want you guys to be very precise with your prescribing. And I see too many prescribers being like, nonchalant about prescribing guanfacine or clonidine because they're two very different medications. Sure, they're both classified as alpha-2 agonists, but there's specific situations where you would lean on one over the other. All right. So no, guanfacine is a selective alpha-2A adrenergic receptor antagonist, right? So it only works on alpha-2A, and clonidine is an alpha-2A, B, and C. Why is that significant? Tell me. What does clonidine do that guanfacine doesn't do?
Clonidine could drop your blood pressure.
Yes. Okay. Very good. What else can it do?
Make you sedation.
Yes. Very good. Yes. So alpha-2A usually are postsynaptic, but they're also, but they also can be presynaptic. Clonidine works on both. It works on presynaptic alpha-2A receptors and postsynaptic alpha-2A receptors. Guanfacine only works on alpha-2A postsynaptic receptors. What is a presynaptic alpha-2 receptor? What does it do? What is it? It's when nothing's presynaptic, it's an autoreceptor, right? So it's a safety shutoff valve. So in a way, if we give someone clonidine and the clonidine binds to the alpha-2A autoreceptor in the presynaptic neuron, believe it or not, it's actually going to reduce a little bit of norepinephrine, right? Now, if it does that to the peripheries, you're going to have what? Low blood pressure, right? Or low pulse. That's why we have clonidine. It affects blood pressure and pulse. Alpha-2B and C, alpha-2B, I'm sorry, is actually on the smooth muscles of your vessels. That's why it causes the blood pressure and pulse issue. Alpha-2C is actually central. So alpha-2A and alpha-2C are in your brain. And alpha-2C, when you innervate that, it actually causes sedation and relaxation. All right. So it makes sense. Guanfacine usually only works for ADHD, right? Clonidine, we use it off-label for a lot of stuff. We use it for impulsivity. We use it for aggression. We use it for ADHD. Some people, I guess some primary care doctors still use it also for the heart, but I don't think they maybe in combination with other things. It's used for anxiety also. It's used for nightmares, right? It dulls down your sympathetic response, so it works for nightmares. So clonidine is much more of a dirty drug because it affects many more receptors, but you might want that. You might want a kid to sleep at night, right? Remember, like I said, if a kid is taking a stimulant and the mom is saying, well, they're not sleeping, maybe I might lean on clonidine because I want them to get sedated at night, help them sleep and help with anxiety, right? Get that 2A, 2C stimulation, right? And 2B also will calm them down. Someone's having nightmares, it's the 2B stimulation. It's going to drop down your blood pressure and your pulse just a little bit to calm you down at night, okay? If I just wanted for attention to augment ADHD, then maybe I would just lean on guanfacine, okay? Child psychiatrists and NPs that specialize in child psychiatry tend to use guanfacine more. Clonidine, we tend to use more in adults because we use that also in substance abuse. All right, we'll talk a little bit more about that when we talk about substance abuse in the next discussion. All right, any questions with this? So clonidine works on presynaptic and postsynaptic alpha-2A receptors, right? Presynaptically, it actually decreases your norepinephrine release, which is why it causes drop in pulse, drop in blood pressure, right? But it also works postsynaptically. When it works postsynaptically, it's an increased focus, attention. It's also going to cause relaxation and reduction in anxiety when it works on alpha-2C receptors, right? When it works on alpha-2B receptors, it relaxes your vasal smooth muscle. So it works, besides in the brain, it relaxes you. Any questions on your peripheries? That's what I meant. know that guanfacine has a lot more drug-drug interactions. Why is that? Why does it have more drug-drug interactions? It's a substrate of a specific CYP enzyme. 3A4. It's a 3A4 substrate, so it'll have a lot more interactions with other medications, right? Remember, 3A4 is the most common substrate for a lot of our meds in medicine, not just psychiatry. So clonidine is metabolized by many different CYP enzymes, so there's not many interactions there, because if you inhibit one, there's still other enzymes that are able to metabolize it. With guanfacine, you inhibit 3A4, guanfacine is going to go up, okay? Know that clonidine, if someone's above, like, I would say 0.2, 0.3, you have to taper them off because you can have rebound anxiety, rebound hypertension on clonidine, right? Taper them off. I taper guanfacine also, but with clonidine, you notice it a lot more. Any questions? Okay, clonidine is non-specific, non-selective. Guanfacine is selective. Okay, guanfacine is used just for attention. Clonidine can be used for hyperactivity, attention, anxiety, impulsivity. There's also studies for clonidine PRN in borderline personality disorder, all right? For PRN for self-injurious behavior. So they use clonidine as a PRN if someone has the urge to harm themselves. Assuming that the patient actually is going to tell you, an inpatient, I feel like cutting myself. Can I please have a clonidine, right? There's studies that show that it actually helps.
Professor Callado?
Yes.
So can you repeat again when you said that guanfacine has more drug interaction because of
Yes.
what?
Because it's a 3A4 substrate.
3A4.
There's many medications that are 3A4 inhibitors and that use 3A4 as a substrate.
All right, thank you.
Right? No problem. Remember, whenever a medication is only metabolized by one CYP enzyme, there's a higher risk of it interacting with other things. All right. Autism. Okay. So just have a general idea of the the symptoms of autism. A lot of times it's more of like issues with verbal, inability to communicate, read facial expressions. They might have some stimming. They might have some self-injurious behaviors too. There's only 2 medications that are FDA approved for autism. Do you guys know? What are the 2 medications FDA approved for autism? I don't want to say what part of autism. It's going to give away the answer, but we'll say it after. What are 2 meds that are FDA approved for autism? Risperidone and aripiprazole, Abilify. Specifically, irritability relating to autism. So sometimes if someone is autistic and they have a lot of aggression and behavioral issues, the most studied and the safest medications that are approved is actually aripiprazole and risperidone. Okay, I would probably use aripiprazole first because it's a D2 partial agonist. It tends to be more tolerable. And then if that doesn't work, a full D2 antagonist like risperidone will be used. Any questions? Is that clear? I have a few kids that I treat now at the clinic that have autism, but they're higher functioning, and they go to a special place for skills training for autism, ABA, and they go to me for comorbid stuff like ADHD or anxiety, and I treat that. But the actual core symptoms of autism are treated somewhere else. Okay. Any questions? All right. So these are the topics that we're going to cover really for the exam. All right. So again, identifying diagnostic clinical features of ADHD, just understand how to diagnose it. Diagnostic clinical features of autistic spectrum disorder, no issues with communication, repetitive behaviors, right? Wanting sameness. They want things always to be the same, right? They want things organized the same way. And if you mess it up, it causes them to act out, right? Or really like causes them to be disruptive. Discuss the difference between subtypes of ADHD, self-explanatory, ADHD inattentive, ADHD hyperactive, and then combined, okay? Mechanism of stimulants, know the difference between methylphenidate and amphetamines. We talked about that before, right? Amphetamines are more potent because they work in the VMAT, and it increases the release of the actual neurotransmitter that way, but they both work on the reuptake pumps, right? NET and DAT. And discuss the mechanism of stimulants, once again, appropriate treatments of ADHD, like I said. You really want to put patients on ER if possible, because that tends to be the most tolerable. But in rare instances, you would use immediate release, right? Like Philip said, if someone has issues with appetite and need to eat in between their doses, that might be an option, right? Immediate release, it starts to trough and go down, you give them a meal, you take the next one. But just be careful with withdrawal and you educate the patients on withdrawal, okay? Distinguish the pros and cons of stimulants and non-stimulants, okay? What are some pros of non-stimulants? Just to review, what is the pros of it?
Lacks abuse potential.
Yes, yeah, very good, right? It also doesn't cause, it can cause psychosis because it's not going to innervate dopamine in the mesolimbic area, and it might not increase anxiety, okay? If anything, it actually reduces anxiety. So there's numerous studies of that atomoxetine actually, through its norepinephrine reuptake inhibition, works with comorbid GAD and ADHD. So you might get lucky and get someone controlled on one medication as opposed to giving them an SSRI, I don't know, like Zoloft and Adderall, right? You're treating the GAD with SSRIs and you're treating the ADHD with a stimulant. You might be able to get away with giving them one medication, atomoxetine, and it'll work. The thing is, it's going to take a little bit more time to work. And you tell the patient, look, it might take a month or 2 to 4 weeks for it to kick in. Okay. Obviously, the pros of taking stimulants, very strong effect size, right? You feel it right away. It works right away. When you take it, you'll feel it if it works right away. Okay. Okay, don't do this. I see a lot of practitioners doing this, and it really gets on my nerves. Don't give a patient like a month's worth of ADHD medication, say come back in a month, and then we'll adjust it. Because I tell parents, what you see is what you get. If you give them a dose of medication, 2 days, 3 days tops, if that dose doesn't work for them, it's not going to work, right? It's not going to work in 2 weeks, it's not going to work in 3 weeks, it's not going to work in 4 weeks. You're wasting the parents' time, right? In order to accurately treat the ADHD, they should be seeing you every week, and you're adjusting it give them a week's worth of stimulants, you don't waste it, and then you adjust it slowly from there, right? It's not like SSRI, they'll give you 10 milligrams, and that doesn't work, go to 20, 30. That's not how it should be treated, okay? Obviously, we discussed that already. There's different, so it's funny, ADHD meds, again, it's using the same, medications, right? Amphetamines or methylphenidate. It comes in like gum form, it comes in liquid form, there's sublingual, there's I think the only thing that we don't have is like suppository. That might be next, right? ADHD med suppository, but it comes in like every formulation. All right, so if a kid can't swallow a medication, you can do a patch, right? Right now, I think there's an amphetamine patch that's out, that's recently came out or is about to be released, but right now that I know of, there's a methylphenidate patch. So unfortunately, if someone only responds to amphetamines, you can't use a patch for them unless this new med that's an amphetamine formulation came out. All right, you have a few options. You can use the beaded formula. They have beads in which you open it, and there's little beads inside. You can put that inside like ice cream or inside of like yogurt or something, and they can take it. But remember, take it in one scoop right away. You don't want it to sit there too long, right? It activates, it doesn't work. Okay. You can even crush it. Some parents they crush the medications and they take it that way, but that's immediate release. You can't crush extended release because it's not going to work. Right, so you can crush immediate release, but you can't crush extended release. But they have extended release, the little microspheres that you can open up, and you can take it that way. All right. Any questions?
For like the pathology, I guess, for ADHD and autism, should we know like specifics or like more like, for example, for ADHD, usually comes from like cortical hypoarousal, and then they say like the delayed cortical maturation.
You should have a general idea. So know that in essence, ADHD is a malfunctioning of the ascending reticular activating system, right?
Okay.
It's a dysfunction in the fact that it's not innervating your cortex, like you said. So therefore, we have to do it manually, quote unquote, by giving like exogenous medications. All right.
Okay.
Autism, no one really knows yet. So obviously, I don't even know the answer to that of what the cause of autism is. So from the brain part, you don't have to know about that, but just know what the symptoms are, from DSM criteria for autism.
Okay.
Stimming, know about issues with communication. Okay.
Okay.
All right. So that leaves us with about a half hour. So what questions are, what questions you have? What's not clear?
Can you go over again the amoxetine? Like how does it work?
Atomoxetine?
Yes.
Okay. So atomoxetine, aka Strattera, is a norepinephrine reuptake inhibitor. So it only works in norepinephrine pumps. Okay. But in the frontal lobe, we only have dopamine pumps. We don't have dopamine pumps to increase dopamine. So what happens when you inhibit the norepinephrine pump in the frontal lobe, it's gonna actually increase dopamine. So by blocking norepinephrine uptake pumps, you're inadvertently increasing dopamine in the frontal lobe. That's why it helps with ADHD. Oh, another thing I forgot to mention too, Clonidine also has analgesic effects. All right. So it inhibits something called substance P in the dorsal root ganglion. So it can also help someone who has pain symptoms. So if someone has pain, anxiety, you might try to use clonidine also as well.
Is clonidine hard to come off of, like once you prescribe it for like long term?
I'm sorry, say that again. Is clonidine what?
Is clonidine hard to come off of, like once you prescribe it long term?
Not from my experience. Yeah, I'm not aware of anyone having a hard time coming off of clonidine.
Okay.
Professor Collado?
Yes.
So can you go back to the topics that you said that we're gonna have on the test and go over the brain circuits? I think was the next topic. Can you go back in a minute and take a look?
Yeah. So you want me to open up the slide again for the brain circuits?
Yeah, because I was late. I'm sorry.
No problem. It's okay. Yeah.
Thank you.
All right, so these are the malfunctioning brain circuits proposed for ADHD. All right, so DLPFC stands for dorsal, DORSO, lateral, that's on the outside, prefrontal cortex, right? And that's for cognition or sustained attention. VMPFC stands for ventral medial prefrontal cortex, right? And that has to do with emotional lability or affect in ADHD, which we see a lot. OFPFC stands for orbital, which is the eye, frontal, prefrontal cortex. So orbital, frontal, prefrontal cortex, and that has to do with aggression, impulsivity. So that's also implicated in mania and schizophrenia also. All right. Prefrontal motor cortex, right? Motor hyperactivity. Can't sit still, they gotta move around a lot. ACC stands for anterior cingulate cortex, which is actually right above your corpus callosum. What is the corpus callosum? It's the part of the brain that connects both sides, right? Your left and your right hemisphere. Anterior cingulate cortex is resting right above it, okay? And that has to do with selective attention. And, it's theorized that dopamine has to do with decreasing the noise of the neuron. And then norepinephrine increases the signal, okay? Which is why sometimes people respond more to dopaminergic medications than norepinephrine medications, right? That's why sometimes you give patients just a norepinephrine alpha-2 agonist, for instance, and they're fine. Because most likely it's just a norepinephrine issue, and they're doing okay. But if there's a little bit of dopamine involved also, you might have to give them a dopamine modulator also, like amphetamine or methylphenidate, on top of alpha-2 agonist. Again, we don't have biomarkers to know exactly which type of ADHD pathology someone has. So unfortunately, there is a little bit of trial and error, right? You might try them on an alpha-2 agonist first and see what happens. You might try them on dopamine agonist first and then try to see what responds. But just know if you're modulating dopamine and that's not working, maybe you're targeting, maybe it's a pharmacodynamic issue. Maybe you need to target norepinephrine, all right? If there's a partial response to dopamine, maybe you'll keep that medication. And then you might have to target the other symptoms by addressing norepinephrine. Does that make sense?
Thank you.
I'm normally in the business of blocking dopamine because I do a lot of schizophrenia, but yeah, you need to do both sometimes. And by the way, you can give someone a stimulant who has schizophrenia. I have a few patients like that actually, that have comorbid ADHD and schizophrenia, and it gets very, very difficult because you need to block dopamine in the mesolimbic area, but you're trying to increase dopamine in the frontal lobe. So you have to find the perfect balance. But that's a little advanced. We'll talk about that once you guys get to the clinical part.
How do the transdermal formulas compare to the oral formulas as far as side effects and effectiveness?
It's funny because I've been trying like forever to get the transdermal, and insurances keep denying it. Because the thing is, I have a lot of patients on Medicare, Medicaid, and for whatever reason, they just don't cover it.
Okay.
Yeah, but from a colleague of mine who does prescribe it, they say it's equivalent. There's no, I guess the thing is, obviously on the side of the skin, it might irritate the skin, or the kids might just peel it off. But other than that, when it comes to them taking it as prescribed, it works just as well as oral meds.
Do they have the same amount of side effects or no?
From what I heard from colleagues that prescribe it, it's the same. No
Okay.
difference. Yeah, no difference.
Can you repeat the medication that you said that does not cause the dopamine or doesn't act on dopamine in the striatum, I think you said it
Yes.
was.
Yes, that would be norepinephrine reuptake pumps. Atomoxetine, which is
Okay,
Strattera, and
It only
Viloxazine,
works in the frontal
which is
lobe.
Clonidine. Only works on the frontal lobe because you don't have, it's not going to work on dopamine transfer pumps, so it's not going to affect the striatum. Anything that blocks dopamine reuptake in the frontal lobe, in theory, in enough doses, can affect it in the striatum also. But if it doesn't have that mechanism, it's not going to affect the striatum, so it's not going to increase dopamine there, which is why it doesn't cause psychosis, right?
Okay, thank you.
Any other questions? Can't believe this. Class is almost over, right? We only have 2 weeks left. Look at that. Get your money's.
Yeah. I was gonna say, you said you're gonna put this as a PDF on.
Yeah, I'm gonna put it as a PDF. Yeah, by tonight.
Awesome. Cool. Thank you.
But why read the PDF when you can just keep watching this video over and over again and get my YouTube views up?
I could do all of it. Why not?
It depends on how you learn, right? Some people are more visual, and I get it. So I'm trying to like make it so it's varied, so everyone can get a learning experience out of this.
Yeah, it's weird with my studying. Like I'll do the notes prior, and then I use the PowerPoint to kind of like write it over, and then I'll kind of like say it to myself. That's how I usually study.
You know what, Alex? I'm not sure. The NEI assignments each have their own certificate. I think they do actually. Last time I took the exam, this was years ago though, but I don't know how it is now.
Maybe so what I did yesterday was the depression side of the assessment, and at the end it's like a few questions, like there were like 4 questions, and then I got the certificate for the depression assessment. That's what I have. I don't know if anybody has done anything related to that assignment.
Yeah, are you talking about like what transcript you need? Is that what you mean? Like if you do all the self-assessments?
Yeah, so do we have to, so each assessment has their own certificate, right?
Yeah.
Okay, thank you.
But I think at the end, it says that you need to take a test.
Yeah, you need,
Complete.
that's what you need, the transcript for that, like that you finish the final exam and then like the transcript.
Yes.
All right, so I guess the question is the final exam is of all 10 assessments?
Yeah, it's all of them.
Mhm.
Okay, so it's not like each assessment has their own final exam.
No, it's like I think it was like 100.
100 questions. It's 100 questions, and it covers all the topics.
I see. Thank you.
Is what I'm saying kind of making sense after you guys read like the style part or read the book? Is it making sense, or is there anything that's like, I don't know, not clear?
No, it makes sense, I think.
Can you talk about treating ADHD and comorbid tic disorders?
Sure. So the thing about tics too is just know they're transient, all right? So sometimes they'll come if it's triggered by anxiety or triggered by other things. So a lot of times they used to say actually that if someone had a tic, you should probably stop the stimulant, but that's not practice anymore, all right? Sometimes what we'll do is, unless it's really, really bad tic and it's impairing them, like they keep having tics and they can't function in school, but if it's like a mild tic that happens occasionally, we can add an alpha-2 agonist like Clonidine and Guanfacine, or we can actually adjust the ADHD meds and find a balance in which the tic doesn't persist, because tics are very strange. Tics are sometimes due to too much dopamine, or sometimes they're actually due to not enough dopamine. And, we don't really understand, and you have to kind of finagle the meds a little bit and try to, find a middle ground.
Right.
So an alpha-2 agonist would be, if someone has a tic and they're doing okay on the stimulant, I would add an alpha-2 agonist on top of that and maximize and see if the tic gets better.
I see. Okay. So not a dopaminergic.
No, I wouldn't. Well, if they're already on a standing, let's say Adderall ER, right, and they're stable, and the mom is saying they're doing great on it, but
right. Okay.
tics got worse, right? Sometimes I'll say let's wait and see, especially if they just started on the stimulant, and see if it just kind of like, again, it's transient, it comes and goes. If it doesn't get better, then of course we'll add an alpha-2 agonist on it also.
Right, okay. Yeah.